All right, well, welcome everyone. I'm Vignesh Murthy. I'm one of the hematologists with the Adult Bleeding and Red Cell Disorders programs at BC and Yukon. And today I will be speaking to you about sickle cell disease with a focus on the pathophysiology and acute complications. Here are my disclosures. And so here's the agenda for the day. So the talk is really divided into two halves, but it's more like 1/3, 2/3. So the first third will be discussing the pathophysiology of sickle cell disease and its clinical implications. And then this latter 2/3 will be covering the acute complications, specifically vaso-occlusive crises, acute chest syndrome, and infection-related presentations. And throughout, we'll be incorporating evidence-based approaches for assessment and initial management. This talk is really directed toward people who might encounter sickle cell disease in an acute care setting or outpatient care setting. So it's really targeted at family physicians, ER physicians, internists, anyone who might see and admit these patients, but who might not have quite as much familiarity with sickle cell disease. But I hope it will be educational for any and all. So getting right into it, in terms of sickle cell disease itself. So what is sickle cell disease? This is a family of disorders characterized by sickling of red blood cells, as the name implies, leading to chronic hemolytic anemia and end organ injury due to small vessel occlusion. The most common variant is called HBSS sickle cell disease, and we'll get into why shortly. That's caused by homozygous inheritance of a specific point mutation in the beta globin gene. Now, taking a step back, most common form of hemoglobin found in adults. So if you look at your CBC and you see the hemoglobin, 95% of that is going to be something called hemoglobin A. And that is the case in the vast majority of adults. And that's a tetramer. It's composed of 2 alpha globin and 2 beta globin chains together. And this is sort of a genetic schematic that explains this, showing that there's 4 alpha globin genes here and 2 beta globin genes here, which code for these proteins that come together to form our hemoglobin molecule that we're familiar with. Now, what's different in sickle cell disease? Due to their beta globin mutations, patients with sickle cell disease don't make normal beta globin, so they cannot and do not generally synthesize hemoglobin A. So that alpha 2, beta 2 that we saw in the previous slide, we don't have that. Instead, they make something called hemoglobin S, and that's alpha 2. It's the same alpha globin, but the beta globin is mutated, as we discussed in the previous slide. And so the difference between hemoglobin S and hemoglobin A, they're both going to show up as hemoglobin on your CBC. You won't be able to tell on that. Is that hemoglobin S polymerizes in deoxygenated conditions. And so that causes the red cells to deform to that classical sickle shape, hence the name of the disease. So what does that mean for patients? Like, why is that a problem? So sickled cells, one, are less deformable and occlude capillary beds. So that vaso-occlusion causes, of course, the hallmark vaso-occlusive pain crisis of sickle cell disease. And secondly, end organ damage due to microvascular infarction. And in addition, repeated sickling, so it's almost like you stretch out a balloon and then if this sickling can reverse, and so you can return to your normal shape, but that repeated process of stretching and releasing results in permanent damage to red cell membranes, and that leads to chronic hemolysis. The red blood cells are more fragile, they break down more easily, and so for these reasons, our patients have a typical baseline hemoglobin of 60 to 90 grams per liter if they have HBSS sickle cell disease, which is the most common variant. And this graphic kind of illustrates that, and you see on the upper left-hand side oxygenated red cells with normal non-polymerized hemoglobin, but under deoxygenated conditions, that hemoglobin polymerizes. It forms these little chains or sticks, and that is what causes your red cell to deform from that nice little biconcave disc that squishes and passes through capillaries into the sickled shape, which does not. And the rest of this schematic really illustrates the other elements of this pathophysiology. So the idea that recurrent sickling eventually leads to membrane fragility and hemolysis, but also that the sickled cells themselves can vaso-occlude and trigger an inflammatory response. And this slide also kind of illustrates that as well. And there's sort of two sides to this. There's this component of, okay, the cells hemolyze, they release plasma-free hemoglobin, which then is scavenged up by nitric oxide, leading to vasoconstriction on one hand, and that leads to certain complications, including pulmonary hypertension, leg ulceration, etc. On the other hand, you have the strictly vaso-occlusive component, where you're you're occluding your microvasculature, infarcting different tissues, and leading to pain crises, acute chest syndrome, and osteonecrosis or AVN. And of course, these things kind of exist in a continuum, and hemolysis and vasoconstriction might make you a little bit more prone to vasoocclusion as well. So they all work together, unfortunately. And how does this affect patients? Well, if you can name an organ system, as you might imagine, there is microvasculature in every organ in your body. So if you can name an organ system, sickle cell disease can and will affect it. From neurocognitive dysfunction to renal failure to functional asplenia to avascular necrosis, infertility, cardiopulmonary complications, and so on. So if you can name an organ system, sickle cell disease will affect it, and there's complications that we have to screen for. Not pictured in this schematic, of course, are thrombosis. Our patients are at increased risk for thrombosis and an increased risk for myeloid malignancy specifically. So that's leukemias, which we've seen in the literature. And of course, that has a number of deleterious impacts on patients' lives. So pain is obviously the biggest one, both the hallmark vaso-occlusive pain crisis as well as chronic pain syndromes. Patients with sickle cell disease have a decreased life expectancy. One study found that there was a median of 54 years in sickle cell disease versus 76 in a non-sickle cell matched cohort, so almost 20-year reduction in life expectancy. And if you look at quality adjusted life expectancy, the difference is even more stark. It's 33 years, less than half as compared to the age-matched cohort. And so, of course, this leads to impaired quality of life. Once I looked at quality of life scores in sickle cell disease and found that they're quite similar to patients with active cancer on chemotherapy. So generally very poor, as you might imagine. And this also results in lost income. And so this figure of 600,000 USD, so for reference, the sort of lifetime income of a non-sickle cell cohort was estimated to be around 1.9 million USD. And in sickle cell disease, that was around 1.2 million. But that estimate was strictly based on the lost working years. So that like 20-year difference in overall life expectancy, that's the only thing they used to calculate that 600,000 figure. The reality is, because of their pain crises, because of the complexity of their illness, frequent admissions, lots of tests, often our patients, in our experience anyway, are underemployed and unemployed. And so the reality is much more, the lost income is much higher than this. Just to illustrate. And so what does chronic care look like? What do we do? So in BC and Yukon anyway, the Adult Red Cell Disorders program based at St. Paul's provides comprehensive care for adults living with sickle cell disease. And our sister program at BC Children's provides care for children living with the disease. And of course, across the country and across the world, there are sickle cell centers. Some are provincial in smaller provinces, and others, for example, in Ontario, are more regional. But there's sort of sickle cell programs, red cell disorders programs, rare blood disorders programs that look after these patients and kind of bring them together to provide comprehensive chronic care. What that entails in sickle cell disease is a multidisciplinary approach: physicians, nursing, physiotherapy, social work, psychology, screening for and management of chronic complications, dealing with management of acute crises and chronic pain as well, management of any other sickle cell complications, so referrals to orthopedics for avascular necrosis, referrals to nephrology for the renal complications, and management of this and others. And lastly, assisting patients in navigating what is a unfortunately complex healthcare system. A number of our patients are new immigrants, refugees, people who are unfamiliar with the Canadian healthcare system. So applying for medication coverage, navigating when to go to the ER, when to contact us, when to see their primary care provider, forms, insurance forms, disability forms. So the system can be quite complicated, and helping patients navigate that is another one of our roles. So where did this all come from? How did sickle cell disease arise? Well, the current understanding is that this mutation itself likely evolved due to its protective effect against severe malaria infection, with over a 90% reduction in severe malaria seen in patients with sickle cell trait. So that's what led to its prevalence primarily in sort of the malaria belt, sub-Saharan Africa, but also the Mediterranean, Middle East, and India. So this mutation obviously arose in heterozygous fashion. People with sickle cell trait, which is generally considered a harmless condition, have protection against malaria. So that was a significant survival advantage for those folks, and that led to the prevalence of the trait. Unfortunately, if two individuals with sickle cell trait have a child together, there's a 1 in 4 chance that child would inherit both beta S mutations, and that leads to sickle cell disease. So it's sort of an unfortunate knock-on consequence of this mutation, which was originally protective for people. And of course, due to the slave trade and global migration, patients with sickle cell disease are found across the world now, including and especially North America. Globally speaking, there's around 7.74 million people with sickle cell worldwide based on a 2021 estimate, with the highest prevalence, of course, in sub-Saharan Africa. An American study suggested around 100,000 back in 2010. Obviously, that number has certainly grown since then. And of note, greater than 90% of individuals with sickle cell disease are of African ethnicity. So not all, but most. And globally, you can see that kind of illustrates here. So sub-Saharan Africa, the Middle East, Mediterranean, and India being kind of the hotspots, and sickle cell disease being a little bit less prevalent, but still present everywhere else in the world. Focusing in on our Canadian epidemiology, this is the Ontario data is from a healthcare administrative database study, which identified 3,400 patients living with sickle cell disease in Ontario. And our BC data is not so much data as just a polling of our program and our sister pediatric program for our patient numbers. And this is probably a little out of date. This number has grown, but there was around 170 adults and 110 children living with sickle cell disease in BC. Now, you might look at these numbers and say, well, why does BC seem to have a sickle cell prevalence that's less than a fifth of Ontario's? And the reason for that is probably demographic. In the 2021 national census, Ontario had roughly 12 and a half times the number of individuals who self-identified as Black. And if you do the math between 3,400 and 280, it's also around 12 and a half times. So it's purely a demographic difference. So that's sickle cell disease in a nutshell. Moving right along into the acute complications. So I'm going to touch on three. The large focus of this talk, honestly, is going to be the vaso-occlusive crisis, but I will spend some time discussing acute chest syndrome and fever as well. So pain, taking a step back. So pain is the most common symptom experienced by patients living with sickle cell disease. In the ER, they're twice as likely to present with severe pain compared to the general population. Pain, unfortunately, in sickle cell is complex and multifactorial. So there's, of course, acute pain related to bone infarction and other end organ injury, and that's the pain crisis. But also they can experience chronic pain due to AVN or central sensitization. And lastly, and perhaps most importantly, people living with sickle cell disease experience a number of barriers to pain management. They're not taken seriously. There's provider misunderstanding of the disease process, systemic racism. A number of factors, unfortunately, come together to make management of pain in this population just not that great. So this is that study from, it's an American study that looked at ER visits. And so, of course, as you can see, compared to the general population, patients with sickle cell disease were significantly less likely to have no pain and significantly more likely to have severe pain. So the vaso-occlusive crisis, aka the sickle cell crisis, aka the pain crisis, the vaso-occlusive event, these are all words to describe the same thing. So this is the hallmark manifestation of sickle cell disease and likely the most common situation in which an acute or urgent care provider may encounter someone living with sickle cell. So what is a VOC? Well, these episodes are characterized by acute onset, severe, continuous, and unrelenting pain. The pain usually includes a bony component, often involving the lower back, the joints, or the extremities. But patients can use a variety of words to describe their pain. You know, they might say it's aching or throbbing or stabbing or sharp or dull. And so, like, there's no one word or specific word that will describe all VOCs. If anything, patients will have their own sort of stereotypes VOC. Like, people often experience their own type of VOC, and they can recognize that, oh yeah, this is a crisis. Because the symptoms and the prodrome are unique to them, and patients get very adept at recognizing these things. The underlying mechanism of pain is not fully understood, partly due to a lack of research, unfortunately, but our current understanding is that it's a mix of acute bony infarction, followed by ischemia and reperfusion injury, as well as an inflammatory response. So real, legitimate, severe reasons for someone to be in very severe pain. I say fast facts, but there's like 6 facts on this page, sorry. Vaso-occlusive crises represent the reason for admission in up to 95% of hospitalizations for patients with sickle cell, with higher costs than asthma, HIV, and CHF. And I'll get into that on the next slide. But the average length of stay in the States is 9 to 11 days. In Canada, I think our data suggests that's a little bit lower. I think we have more an average of maybe 5 to 6 days, but it's still pretty long. Untreated or undertreated vaso-occlusive crises can lead to other potentially life-threatening complications related to sickle cell disease, including acute chest syndrome, which we will get into later, and multisystem organ failure. And frequent vaso-occlusive crises have been shown to have a greater impact on patients' quality of life than sickle cell-related organ damage. And of course, they're all also associated with increased mortality. And perhaps the saddest fact here, honestly, to me, is that patients with sickle cell may experience their first pain crisis as early as 6 months old. It's very hard to think about a little infant with such severe pain. So looking at ER and hospital usage in sickle cell, so this slide is a little busy, and I'm not going to spend too much, time on this, but the key is that the estimated size of, so this was an American study that looked at ER and inpatient usage in 2006. And so at the time, the estimated size of the sickle cell population was 100,000 compared to 4.8 million people living with CHF in the States. That being said, although the charges for like the cost of any individual admission was about the same except for HIV, which is a bit of an outlier, 20, 25, 30,000, because they were admitted so much more frequently relative to the number of people living with the condition, the cost per 100 patients is actually higher in sickle cell disease compared to all 3 of these other conditions. So that's where that comes from. It's not that the individual admissions themselves are more expensive, it's that they are admitted so much more often relative to those with other chronic illnesses that the cost for sickle cell disease as a whole is quite high relative to the size of the population. Now, Canadian data is more limited, but our colleagues in Ontario did perform a matched cohort study using data from 2006 to 2018. And they found that compared to a matched non-sickle cell cohort, sickle cell disease patients' ER visits were associated with a higher likelihood of CTAS 1 or 2 triage, much more likely, much higher likelihood of admission, longer length of inpatient stay if they were to be admitted, and a higher rate of repeat ER visit within 30 days of discharge. So the ER usage is significant. Now, there is no single diagnostic test, biomarker, or exam finding that's diagnostic of a VOC. The diagnosis is clinical. It's based on a presentation consistent with the patient's known history of VOCs and, to an extent, exclusion of other potential causes of pain, chronic pain, AVN, osteomyelitis. Extensive diagnostic testing, that being said, including labs or imaging, is not actually required to diagnose a VOC and definitely should not delay initiation of therapy. A number of triggers and inciting events can precipitate a crisis, and identifying one of the following can be helpful in making the diagnosis, but it's a pretty long list. Anything from infection, dehydration, hypoxia, cold exposure, sleep deprivation. It's a long list, right? And the cold weather is subtle. Like if you have, for example, a series of warm days in the summer and then just one unexpectedly cold day, we find often enough, at least one or several of our patients is telling us that they have a crisis. Because they didn't expect the cold, they didn't bundle up completely because it's still summer or fall, and they end up having a crisis, especially if they work outside, but even just going out. But, this happens to students staying up late, sleep deprived, studying for an exam. It happens to young women on their periods. It happens in the setting of surgery. So a number of these factors can be important in identifying. And so what would you like to see in the ER or inpatient setting as far as a workup if these patients are not admitted at one of our centers, for example? A pain history is the usual LPQRST, but really, does this feel like your usual sickle cell crises? And that's perhaps the most important question to ask to help understand whether this is a pain crisis. Identifying a trigger, definitely asking them what pain medication they've used so far. So VOCs are not new to the vast majority of these patients. They have pain medication at home, including opiates like morphine or hydromorphone, and they'll use something. So understanding what they used and how much they've used and whether that's worked or not worked at all is important. Did their pain go from a 10 to a 7? Did it stay at a 10 despite hydromorphone? Like that should influence how you manage them afterward. And of course, screening for red flags, namely fever, respiratory symptoms, and infectious symptoms. And we'll get into that a little bit more. The exam is relatively straightforward. It's a general cardiorespiratory abdominal exam, and then maybe a targeted MSK exam of any affected limbs that they're complaining about. The investigations are also relatively quick. Some basic blood work, chest X-ray, and ECG. That's really it. That's all that's really required up front, unless there's some red flag or something else that's unusual. So what are those atypical features, red flags? So I mentioned some of these other things that could present like a VOC. So, if someone has isolated localized extremity pain, like, oh, it's just this bone and it nowhere else, and plus or minus erythema or point tenderness, do consider osteomyelitis or AVN. That might be a setting where you want to get a CT or some other imaging to diagnose that. If they have specifically dyspnea, pleuritic chest pain, or hypoxia especially, without kind of any other pain elsewhere, consider acute chest syndrome or PE if the chest X-ray is clear. And if they have severe abdominal pain without a bony component, consider cholecystitis, appendicitis, or pancreatitis. Of course, these patients are at high risk for gallstones, so that's where the cholecystitis and pancreatitis come in. But second kind of bottom line, any of the above can coexist with or trigger a vaso-occlusive crisis. So even if you're thinking it could be something else, you need to treat the pain really aggressively while completing your workup. So brief summary of that portion. VOC is the most common cause of bony pain in sickle cell disease. Patients often have characteristic individual sites and characters of pain, which they know very well. So really, bottom line is to trust the patient when they say they're having a vaso-occlusive crisis, because there are no specific signs or features that are diagnostic of VOC. However, provided there's no features of an alternative diagnosis, no red flags, a patient can and should be treated presumptively as having an uncomplicated vaso-occlusive crisis. And so the typical course, so that 9 to 11 day admission figure from earlier, you can kind of see that there's a prodromal phase. Before the crisis, patients sometimes have numbness, paresthesia, something just feels off. And then that leads into the crisis, which very rapidly escalates in severity in terms of pain. And then sort of also rapidly comes down. So any of you who've seen a patient with sickle cell disease might find that they're in severe pain one day and the next day it's like gone. And that is the common, sort of expected thing that will happen. And the goal really, and the reason I really put this slide in here is that this is our goal, is to hit them right here, is to early in the crisis, before the pain really escalates, early aggressive intervention in an ideal world would blunt this. So instead of going all the way up here, we kind of just stop and settle out much earlier, leading to shorter admission or no admission. And so what is the treatment of a vaso-occlusive crisis? I'm sure you've all seen it's pain control, but what kind? And so the bottom line is it's multimodal analgesia. And this includes all of the following: so an opiate, an anti-inflammatory, and Tylenol, with the goal of therapy being to reduce patients' pain by 30% by self-report in the first hour. So this is a sample pain control regimen for ER or inpatient settings for someone who is not on chronic opioid therapy, who's not kind of on daily morphine, hydromorphone, who's not opioid tolerant, in other words. And so the takeaways here are that we're scheduling and maximizing both the Tylenol and the NSAID. It's not a PRN. And we find this is one of the things I've seen, at least in my experience, most frequently is when patients are admitted elsewhere, we're seeing a lot of PRN, Tylenol, PRN, they're ordered. The NSAIDs and the Tylenol are ordered, but they're PRNs in addition to the morphine. And so that we find is not as effective as scheduling those things as sort of the backbone of your pain control, and then just having the breakthrough hydromorphone as your addition. And obviously the other major takeaway here is that I've highlighted Q15-minute hydromorphone dosing. So that's very frequent. It's obviously not sustainable. But at minimum, people may need medication every 1 to 2 hours until their pain's under good control. And of course, we try to consider patient-controlled analgesia if frequency is an issue, and especially if they're ever admitted. But this is obviously not sustainable outside, even in an ER setting, it's not sustainable for too long. But it's important to try and aggressively treat these to kind of abort the need for admission. And of course, there's adjuncts. There's decent evidence for both ketamine and regional anesthesia as sort of opioid-sparing adjuncts that we sometimes use in the inpatient setting, showing that these two modalities can reduce opioid usage and are relatively well tolerated with limited side effects. Supportive care-wise, the three main things I want to highlight are fluids, DVT prophylaxis, and incentive spirometry. The fluids is a bit of a gray area. Like I think at least a lot of people tell me that they try to rehydrate patients really aggressively, and I've seen that myself, that patients are like getting tons of fluid, maintenance fluids. And so the problem is, yes, dehydration is a common trigger for vaso-occlusive crisis, and yes, patients in severe pain might not be drinking well. The issue is that overhydration can cause volume overload, precipitate acute chest syndrome, and so the goal here is to restore euvolemia and then just saline lock them if they're drinking well. So the exam is dehydrated or dry, go ahead and give them a fluid bolus, but then saline lock them as soon as they start drinking properly. DVT prophylaxis pharmacologic is important. These patients are at high risk for thrombosis. And incentive spirometry, there's mixed evidence for efficacy, but it's a harmless intervention, so we generally recommend it in all patients admitted for VOCs. So in summary, we're looking at multimodal analgesia, certain pain adjuncts if people aren't improving within 24 hours, supportive care measures, and the last thing I didn't highlight so far was continuous reassessment. So this is not a patient, unfortunately, you can kind of step away from for 3, 4, 6, 12 hours. It's someone that you kind of want to check in on at least every hour or two, just to make sure, at least in the first few hours of their visit or admission, that things are moving in the right direction. Because the problem is if you leave them too long and their pain is just poorly controlled for 24, 36 longer, you run into complications. Patients can develop an acute chest crisis, acute chest syndrome as sort of a complication of an untreated or undertreated vaso-occlusive crisis, and in addition to a number of other complications. So the bonus, this is a sort of a sample outpatient management plan for those of you who work in urgent care settings, family doctors working in private offices. So if these patients come to you and they say that they're having a pain crisis, these can be managed as an outpatient. Like they don't always have to go to ER, they don't have to be admitted all the time. So it's a lot of the same, right? You're informing patients to stay warm, stay hydrated, avoid exercise and stress, try to rest. Patients with sickle cell disease frequently come from countries that are warmer. They are not used to the cold, and they may not be even aware that they need to really take extra efforts to stay warm when they're here in Canada. Multimodal analgesia, it's the same types of medication, right? It's still Tylenol, an anti-inflammatory, and an opiate, but of course the doses and routes are slightly different. And the safety netting here is to have patients contact you back or proceed to ER if they're having worsening pain, any dyspnea, any fever, or lastly, if they're just not responding to 3 doses of opioid. At that point, you're probably not going to get too far with oral hydromorphone, and they probably do need to come in for an assessment and IV opiates. So interestingly, Health Quality Ontario has outlined several standards for the care of patients with sickle cell disease. Pertinent to vaso-occlusive crises, those of the VOC should be triaged as CTAS 2 or higher, and those of the VOC should receive analgesia within 60 minutes of presenting. Now, for reference, CTAS 1 patients are supposed to be seen by a physician immediately, and CTAS 2 within 15 minutes of triage. That's per the CTAS guidelines. Now, obviously, that is not necessarily happening in practice, like in any ER, in any setting, like even outside the sickle cell world. And that's just because of our overburdened healthcare system. But this is sort of the goal and the gold standard. The available evidence does suggest, however, that patients in Canada, with sickle cell at least, do not receive timely or adequate quality care in the ER, unfortunately. So an Ontario review of 1,800 patients and 13,000 ER visits found that although, yes, they were far more likely to be triaged as CTAS 1 or 2, 66% versus 18%, the wait times were not actually different compared to age-matched controls. Like, even accounting for their much higher triage acuity scores, these patients were still waiting just as long as the general population who had a lower average CTAS score, essentially. So the more acute triage didn't seem to make a difference, and that is a problem. And so this is why I highlight that we have to really try and treat pain seriously. These patients are a racialized, marginalized group with a high degree of medical mistrust and a history of difficult encounters with the healthcare system. And as discussed in the previous slides, acute pain in sickle cell disease is very real. It's caused by tissue injury, ischemia, but it's often undertreated, misunderstood, or just not taken seriously. This is our anecdotal experience, and our patients have told us like they've left the emerge after not being seen or not receiving therapy for 2 hours. Patients on chronic opiates have received the opioid-naive dosing of hydromorphone, so not enough. And patients have felt like they're not taken seriously, treated as drug seekers. We've had multiple patients tell us that they overheard staff members talking about them in this way, like just outside their room or just down the hallway, and it affects, it obviously causes a worsened medical mistrust, and it makes caring for them much, much harder. And this is sort of a side point. I didn't highlight it in the agenda, but I will spend a few slides talking about transfusion. So a frequent question that we receive as hematologists is whether these patients, when they're presenting with a VOC, can or should be transfused. The short answer is no. Patients presenting with an uncomplicated vaso-occlusive crisis in general should not receive red cell transfusion, but I'm going to go into why that is, the risks for transfusion in sickle cell disease, and the rationale for why we usually don't recommend it, especially without discussion with hematology beforehand. So the risks, of course, can be summarized into sickle cell specific and general risks. In sickle cell disease, there's something called alloimmunization, which is much more significant in sickle cell compared to the general population, and I'll go into that in more detail. But that increases the risks
the
of...
Apple Store is...
Sorry. But that increases their risks of delayed hemolytic transfusion reactions, hyperhemolysis, and an inability to find units in the future. Hyperhemolysis itself is a potentially fatal complication of transfusion in sickle cell, and hyperviscosity is also seen when their hemoglobin rises above 100 or 110. And of course, we face all the same risks as any other population receiving transfusion: iron overload, other transfusion reactions, and complications related to central access if it's required, including thrombosis or infection. So what is alloimmunization? So this is the process of forming an antibody to a foreign antigen present on a donor red cell. So as of 2025, there are 47 recognized blood group systems, so that's like Rh, Kel, Duffy, Kid, but 366 different red cell antigens that may be carried on red cells. And this is to some extent genetic. The way I describe it is that every individual inherits a unique sort of signature, and everyone's red cells will have their own different pattern of these red cell antigens. And the problem is there are ethnic differences in this. And as the sickle cell population is overwhelmingly Black, and our donor population in Canada, in a North American context, is overwhelmingly Caucasian, there are donor-recipient mismatches. Like transfusing cross-matched red cells doesn't necessarily match for all of these antigens, and it cannot. Our routine matching, the basic routine matching, covers ABO and RH, and in sickle cell, we do recommend extended matching for all the other RH antigens as well as Kel. But the reality is there's still a number of antigens that are sort of not necessarily matched for in transfusion. And so in the general population, as you might expect, anyone can form an antibody to a foreign antigen. In the general population, that's around 1 to 3%. In sickle cell disease, especially in the North American context, those rates are as high as 50%, so much more significant. And what that means for patients is once they have an alloantibody, it is harder to find matched units of blood in the future, because now you have to find units that are negative for whatever that antigen might be, and it might be a rare one. They have higher rates of delayed hemolytic transfusion reactions. They're at increased risk of this hyperhemolysis syndrome, which is potentially fatal. And so for all of these reasons, we emphasize every time, please do not transfuse them without discussing with us. And so there's often this question of symptomatic anemia. So of course, everyone here is likely familiar with that threshold of like 70 grams per liter. It's often where we start transfusing our medicine patients, ICU patients, and so on. So providers unfamiliar with sickle cell disease are sometimes surprised by our patients' low baseline hemoglobin. They might run around with a baseline of 60, 66, and so they ask us about blood transfusion. And so I think the best way to address this question is to, one, ask, well, why are these patients anemic to begin with? And then what is an appropriate target hemoglobin, if any? So first of all, why are they anemic? Of course, there's chronic hemolysis due to repeated sickling. But actually, we think the more prominent reason why their hemoglobin are so low to begin with is that HbS has a lower oxygen affinity compared to hemoglobin A, which means the patients with sickle cell disease have better tissue oxygen delivery at lower hemoglobin levels compared to the general population. And as such, they have a reduced erythropoietic drive. If their tissues are getting enough oxygen with the hemoglobin of 70, then there is it's not like their body is trying extra hard, releasing tons of EPO to make lots more red blood cells for that reason. Of course, they have tons of RBC turnover due to the hemolytic anemia. And so they do make red cells at a much higher rate than the normal population, but they have a lower drive to make more red blood cells for this. And this is probably the bigger reason why they're anemic. And so what I really want to highlight is that the patient with sickle cell disease and a hemoglobin of 70 is not the same as a general medical patient with a hemoglobin of 70. And although you might want to transfuse this person, you should not transfuse this person without a very good reason. And so what are these indications for transfusion? When do we think about it? So our typical acute indications are acute chest, acute stroke, multi-organ failure, splenic sequestration crisis, aplastic crisis, the perioperative setting, and lastly, symptomatic anemia. But I highlight that to us means a hemoglobin less than 50 or 60, or a significant drop from their baseline, plus some symptoms of anemia, like dyspnea, chest pain, presyncope, or if we're convinced that they're having active organ injury related to anemia. So it's very nuanced, and the vast majority of patients presenting with a vaso-occlusive crisis should not be transfused. So yes, note the absence of vaso-occlusive crisis on this list. It's not an indication for transfusion. We should not be transfusing these patients generally. And so that was my bonus transfusion section. So I'll move right along into acute chest syndrome. So this is an x-ray of one of our patients who was admitted with acute chest syndrome a few years ago. It is pretty scary. So what is ACS? I realize ACS in medical training is acute coronary syndrome. We in the hematology world shorten acute chest syndrome also to ACS, so this can be confusing. But acute chest syndrome is a potentially fatal complication of sickle cell, characterized by acute onset fever, respiratory symptoms, and pulmonary infiltrates. It's the third leading cause of death in sickle cell, the first being infection. Case fatality of around 3% in the reported literature. Patients can present to the ER with ACS up front, or they can develop acute chest syndrome while already admitted for other reasons. And the disease, of course, can range from mild, treatable as an outpatient, to severe, requiring intubation, mechanical ventilation. So what's happening here? It's thought that there's some kind of initial insult or injury reducing alveolar oxygen, leading to pulmonary vascular sickling. So, maybe they have an infection, a pneumonia, they have a fat embolism, they have some kind of trigger that leads to decreased oxygen tension in the alveoli. And that decreased oxygen tension in creating deoxygenated conditions leads to sickling. Then sickling in the pulmonary circulation causes that circulation to become very sluggish, and so that predisposes the patient to further hypoxia, further sickling, and tissue injury. A variety of triggers have been implicated. So as I discussed in the previous slide, infection is a big one, may cause up to 38% of cases, both pulmonary and extrapulmonary infections like bacteremias, surprisingly are implicated. Vaso-occlusive crises, especially if untreated or undertreated, partly due to perhaps splinting or atelectasis when they're admitted. Pulmonary embolism, fat embolism, and then surgery and pregnancy, some of the other big ones. And there's only two criteria required to diagnose acute chest syndrome: fever and/or respiratory symptoms with a new infiltrate. So that's it. Fever, symptoms, infiltrate. And you may have a fever and an infiltrate, or just symptoms and an infiltrate, but the infiltrate's important. That's it. So hypoxemia is not required, but can be a marker of severity. And ACS may be indistinguishable from community-acquired pneumonia. So when we hear that, oh, we think your patient has pneumonia, we worry, oh no, we think they have acute chest syndrome. Because functionally, you really cannot distinguish between these entities. And it's always acute chest syndrome until proven otherwise. So these patients definitely need hematology involvement. If there's any question, if they have a new infiltrate, absolutely call us. But the mainstays of therapy are empiric antibiotics covering common and atypical respiratory pathogens, supplemental oxygen, with a target. 95% is probably a sort of a collectively agreed target, but the target's honestly not clearly defined in the literature. It's not 100%, I can say that. VTE prophylaxis, pain control, but monitoring for opioid-induced hypoventilation, which could worsen the hypoxemia. The fluids here, this is really important. This is really only enough and only if required to correct hypovolemia, because overhydration can definitely worsen acute chest syndrome. And lastly, a bit of a diagnostic workup and transfusion. But honestly, the bottom line is call hematology. If there's any concern for acute chest syndrome, absolutely please don't hesitate to call us. We want to be involved and we can provide advice because especially around transfusion, these patients frequently may require exchange transfusion, which in BC and Yukon is only delivered really at VGH. So this would be a sort of life or limb transfer to VGH for exchange transfusion if someone had severe acute chest syndrome. And lastly, and briefly, I'm going to discuss fever. So, first of all, patients with sickle cell disease are functionally asplenic. They are immune compromised. And that functional asplenia occurs in up to 94% of patients with HBSS sickle cell disease by the age of 5. Infection is the leading cause of death with sickle cell disease. In autopsy studies, they found that up to 48% of deaths in sickle cell disease were attributable to infection, and that's in a North American context. The numbers are higher if you travel to Africa, actually. Prior to guidelines recommending routine penicillin prophylaxis in infancy, bacterial infection had a case fatality of 35% in patients with sickle cell disease. However, in the randomized prop study, penicillin prophylaxis started in infancy reduced the rate of infection in children with sickle cell disease by 84%. So routine penicillin prophylaxis is actually recommended for all children living with sickle cell disease starting at as early as 2 months of age. But fever is a red flag. If the way someone very wise explained this to me and to a patient is that, unfortunately, when someone tells us they have a fever, especially over the phone, we cannot tell the difference between a life-threatening bacterial sepsis and kind of harmless virus. So any fever in sickle cell disease potentially represents a life-threatening infection in an immune-compromised patient and merits urgent and immediate attention. So one, empiric antibiotic, ceftriaxone upfront, and then considering azithromycin or vanco if in the appropriate situation. Absolutely blood cultures and a chest x-ray for everybody, plus or minus other infectious investigations depending on the presentation. And potentially an admission depending on what you find. That was very brief, but that is all I have to share today. Lastly, I've included a slide as far as how you can find us. This is on the header of almost all of our clinic notes. And here are my references. And I'm happy to take questions.
Thank you very much, Dr. Murthy. It was excellent. When the hematologist learn from another hematologist, that was a really good presentation. So please let us know if you have any questions.
Yeah, hi. This is Mahmoud Sirda from York University.
Hi, Mahmoud.
Hello. Yeah, hi. Thank you. Thank you for the very nice lecture and presentation that provide very interesting information about sickle cell anemia in terms of the homozygous with two variant in the hemoglobin sickling. So my question is, if you encountered in your practice co-inheritance of beta thalassemia and sickle cell, which is very common in Canada. So do you have any clinical data about co-inheritance of hemoglobin S with beta thal?
We do. So I think in a North American context, from as far as I've been able to find, the rates of different, so sickle cell genotypes, in North American context, it's around 75% HBSS, about 20% HBSC, and 5% sickle beta thal on average North America. Our numbers are roughly like that. I think in the adult program, out of our 170 patients, we have maybe, I want to say 5 or 10 who are sickle beta thal. So the numbers do bear out. And obviously in other parts of the world, the sickle beta thal is a lot more common. So
Yeah, especially in Southeast Asia and in the
yes,
Middle East. Yes,
in
I am
Greece,
from
yeah.
I am from the Middle East. I am from Palestine, and I am one of the team who proposed the obligatory premarital test before marriage for beta thalassemia, and so I am interested in this context, and I want from your clinical experience. I am not a clinician. I am a biologist. However, I want to know from your experience if you can compare from your clinical experience any cases with beta thal, co-inheritance of beta thal with sickle compared to the homozygous sickle cell.
Good question. I think for practical purposes, they're considered functionally equivalent. Patients with sickle beta thal, like although they have microcytosis, their
Yeah,
hematologic parameters, otherwise the anemia, the severity of sickling, the incidence of asplenia, infection, and other complications are
yeah.
basically they're considered functionally identical in our practice,
No,
and they
no.
are treated the same. Yeah.
Yeah. Thank you. But I am asking because of the different severities of the beta thal. Sometimes beta zero, beta plus. So sickle cell is the same mutation. However, for beta thal, we have until now more than 350 different variants that causing the disease. So what are the common types of beta thal in Canada? I am new in Canada just 2 years ago, and I don't know what are the most common variants Canada, whether beta zero, beta plus, the severity of the mutation. So this will be reflected on the severity of the clinical manifestation of the disease.
That's true. I think in our context, it's more beta zero than beta plus, but we do have a handful of sickle beta plus who obviously, yes, they have a much milder phenotype because they have often the phenotype in sickle cell disease for the rest of the audience is to some extent related with what percentage of circulating hemoglobin is HbS. So if you have a
Yeah,
beta zero mutation where you have no normal beta globin, it's
yeah,
functionally the same as
that's correct.
HbSS, but yeah. When you have a beta plus mutation where you might make some normal beta globin, those
Yeah, that's
patients.
normal. Yes, and this will make the clinical symptoms better. So
Yes, yes,
yeah.
yes. Yeah.
Thank you so much for this interesting lecture and presentation and the information you provided in during this session. Thank you so much.
Okay, we have a question from Dr. Singh. So thank you for the excellent presentation. Acute chest syndrome, would you be able to comment on the role of non-invasive ventilation, for example, CPAP for prevention or early use to modify the severe clinical course of acute chest syndrome in admitted patients? Is it something that you use in clinical practice?
That is a good question. I think in practice, I have not seen quite as much CPAP or BiPAP in the adult world. And Dr. Hamid, you might have more experience on the pediatric side. In adults, I think often we're usually just escalating the oxygenation kind of nasal prong space mask up to high flow nasal cannula. I don't know of any literature that suggests that positive pressure ventilation specifically can like non-invasive positive pressure ventilation can um, lessen disease severity or sort of avoid intubation if that's going to be something coming down the line.
So really, from pediatrics perspective, is a really interesting question. Um, the reason for me that is interesting is I have to go back 10, 15 years ago to remember, look at the number of patients that were in that middle zone, that whether we were considering doing CPAP or not. Nowadays, with advancement of care, hydroxyurea, patients coming, we see much less sickle acute chest syndrome, but when they're really sick, and they end up going and getting like a full intubation. At that time, I remember I was at Sikis, I was a trainee, and we were debating like as general practice, whether there's a benefit of using CPAP for people with sickle cell and whether this actually makes it worse. So my knowledge is, I have to say, it is not the greatest for this, if things has changed since then or not.
From Dr. Serby, I see the tax trial. So in our practice, we have not. So this is a recent study. It came out just in April of this year that looked at therapeutic anticoagulation, therapeutic low molecular weight heparin given to patients submitted with acute chest syndrome. And they found that it did reduce I think it reduced the length of admission, and they reduced the severity of the course as well. But our practice, we have not. To be honest, I don't know that we've actually had a severe acute chest since that trial was published. But it certainly is a very interesting result and kind of unexpected. Especially in that there was no increase in bleeding really, but that was all a bit of a surprising study. But I think I am curious to see if we're going to collectively integrate that into our practice.
Any other questions? In the meantime, I just missed a comment from Dr. Uminsky that she confirmed that we do see a heterozygote, like there's a wide variation in the phenotypes of the people with beta sickle. Excellent. So I think there's no more questions, and wonderful. Thank you so much, everyone, for attending, and especially to Dr. Murthy for this wonderful presentation.
Thank you all for attending and listening. Thank you to CanHaem for inviting me to speak to you all, and I